we will go ahead and talk about definitely mission harm reduction, the innovative approaches to save lives. Now, this becomes another very important and I would like to say a very thoughtful subject to talk about. Now, 2 years ago in November 2020, the Times Group curated a thought leadership platform to push the narrative around consumer choice, highlighting the need for progressive regulations. Now, based on not just science and or just the bans, but even more than that. The initiative aims now to discuss the harm, the reduction in the major sectors regarding the consumer choices, their freedom, including but not limited to just the cryptocurrencies for that matter, the sugar, the gaming, the healthcare, the tobacco, or the plastics, the alcohol, and the like. We would like to bring to your attention the discussion on consumer freedom with the intent of not limiting the consumer choices. And I'm sure that's how everybody would like to hear as well. The platform will make an effort to impress upon the decision makers the need to stop, ponder, and in fact ruminate around a long-term view of the social and economic impacts of the legislation that look to just ban and not regulate the different products in the free market. So I'm sure some very fresh perspectives are reigning right there, and I'm sure whatever you heard from Sir right now, whatever you felt was something that could be tweeted and shared on social media, please do not hesitate to use our official hashtag, which is hashtag ETGBS, hashtag scripting the economic change. Ladies and gentlemen, I am happy to be inviting the discussants for this panel discussion. My hugest regards for the expertise they will bring onto the table. May I please request Dr. Kiran Melkote, the orthopedic surgeon, member of Association for Harm Reduction, Education and Research, to please step on the stage. Let's welcome him with a beautiful round of cheer. Thank you, Dr. Kiran. Let's also welcome Upendra Nath Sharma, partner, JSA. Mr. Sharma, warm welcome to you. Let's also welcome David T. Sweanor, the JD Chair of the Advisory Board, Center for Health Law, Policy and Ethics, University of Ottawa, Adjunct Professor, Faculty of Law, University of Ottawa, Global Leadership Council, Boston University School of Public Health. A warm welcome to you as well, David. Very, very hearty to see you. Let's also welcome Dr. Madan Gopal, the Senior Health Consultant from Niti, Aayog. Dr. Gopal, thank you so much. Your stature means a lot and really looking forward to hearing from you. Coming from an industry body, thank you very much. Maybe also request, please, Professor Dr. Nimesh G. Desai, the former Director, Institute of Human Behaviour and Allied Sciences, to please step onto the stage as well. And ladies and gentlemen, our discussants are all set to shine the light of their talk. But to chair this discussion forward, may I please request to don the hat of a moderator. May I please request Supratim Chakraborty, the partner corporate commercial and technology practice from Khaitan and Co., to please come forward with all the enthusiasm. I hope you're all set to go ahead into the discussion. Over to you.
Thank you so much. We have a stellar lineup of speakers here. I've spoken with many of them before, so ladies and gentlemen, let me pre-alert you that this is going to be very, very interesting, and it may just overshoot the clock that's showing here, okay? I hope that no one has taken a smoking break before this, because we're going to center our discussion a lot around that and harm reduction, etc. Before we begin, I think let me give a very wild, weird example so that, we kind of do a bit of context setting, but not specifically what we want to talk about as the heart of our discussion. Imagine there is like a highway or an expressway and people used to sort of cross over and meet with accidents, okay? And then people thought of a solution that why don't we have a foot over bridge, okay? And foot over bridge was constructed, and then people saw that probably people would slip walking up and down the stairs. So what happens is we stop the foot over bridge operation. Rather, we see that let's put up a larger, maybe a signboard on the road. Please be careful when you're crossing the road. Or probably for some time we put a policeman there that, why don't you sort of try and control people who are trying to, cross over. So probably accidents will still happen. But what we did not do, probably check that can we put some kind of rubber padding on the staircases and see if we can still make that work, right? So it's a weird example, but you'll soon get to know why I'm talking about all this. So tobacco harm reduction is a contentious issue in tobacco control, and governments around the globe are doing a lot. I think our government here also sort of needs to be lauded. A lot of good initiatives have been taken. For example, banning on the ads of tobacco products, or say no tobacco related products sale to people who are below 18 years of age, so on and so forth. There are certain other governments who are getting aided by certain products which are probably scientifically checked and are a good substitute. So with that, we want to sort of jump into the conversation today. The questions for all of us to ponder through this journey would be: is there a way to stop people from consuming tobacco? I think we just heard, Chauhanji before this, and spectacular, very, very nicely put, that the issues in relation to tobacco. Is there a way for them to overcome their addiction to smoking? Is there a way to replace these products with less harmful products with proper regulations in place? Let's find out with this panel now. My first question is to Dr. Madan Gopal, sir. So I believe India has about 300 million tobacco users, and the government's goal is to reduce this tobacco usage by 30% by 2030. My question is, how likely is this scenario?
As Mr. Vishal Chauhanji has mentioned, that we have a program, NCD program, and we have making efforts. The government has made 3 efforts for harm reduction. One is increasing the taxes in line as suggested by WHO. The second is banning the smoking in public places. And the third one is advertisements, warning on the advertisement. The size of the warning has increased. These are few of the steps. But the important challenge which we are facing is tobacco consumption. We have to make people aware, because the way things are happening, so reducing 30% of tobacco usage by 2030 is a little challenging. So we have to have some mechanism that how to reduce the harm. As a public health person, I know that tobacco is very harmful. If it is harmful, then we have to see that how to reduce that harm.
Right.
We cannot be having a separate kind of mechanism that can get these are alternates. What is less poison, what is more poison? Poison is poison. And apart from that, we are aware about that tobacco consumption. We are only focusing on the cancers. As from the public health perspective, you see that even if I create 1 lakh beds for cancer to take care of the cancer, are they sufficient? They would be taken over in 1 year, 2 years, then you have to think of more beds. So prevention of cancer is one death, and one of the social determinants, because social cultural aspects are there, and how to reduce the tobacco consumption. Tobacco is not only causing cancer, it is affecting your sperm count, it is causing miscarriages. If it's having a wide range of effects. So if you look at in the rural areas, as he has mentioned about the major focus has been the reproductive and child health care in the initial approach, in which if you look at the miscarriages in the community, then you will be surprised that they are consuming tobacco.
And I think tobacco in multiple forms, right? It's not only smoking. Like when you go down to the grassroots level, you'll understand that the various modalities through which it is getting consumed, those are also quite alarming and needs to be taken care of and taken into account.
That means the harm reduction strategy, which is currently focusing on building capacities, awareness, and dealing with how to reduce it in the form of regulation and other things. That strategies are there, but we have to see that it's a time to pause, stop, and see that whether they are working or not. You have to take a 360 view. Why people they are not stopping? Increasing the taxes, tobacco taxes, has it increased the revenue? If you do a socio-economic cost calculation, so from the public health perspective, you have to have measures for how to bring in the cessation. The alternatives are the other thing, whether they will work or not is too early, because people they are very skeptical about that.
Excellent. I think that is a natural segue to what I will ask you, Dr. Melkote. I know you for some time now, so I'll get a little personal. So basically, you are here both as a doctor and an ex-smoker. Okay, so you have seen both sides of the spectrum. My question to you is, do you feel that the current tobacco cessation programs are adequate?
Okay, I think what we need to look at here is what is our rate of success. The problem is now we have only a single-minded approach. I'm actually not talking about the uptake part. So what do we do about the 267 million users who are currently on tobacco? We only have one approach for them: quit or die. So we are trying to get them to quit by a range of, on paper, by a range of techniques. For example, counseling, there's a quick line, maybe some NRTs. But what happens in reality is, you go to a shop, they don't have enough stocks of NRT for 90 days. You need to have some NRT for 3 months. They don't have it. You try various other drugs like maybe bupropion or varenicline, the same story. Luckily for us now, if you actually look at NRTs, nicotine replacement, that has come into the national list of essential medicine, and I think that's a great step. Hopefully now the cost of NRT should come down, because if you look at that number, that 267 million people, of that 28 million are only smoking cigarettes, 72 million smoke BDs, and so about 200 million are on oral tobacco, which means your zarda, ghutka, khani. We tax the hell out of cigarettes. We don't do that to BDs, we don't do that to oral tobacco. So you have about 10% or about 15% of the entire problem who's paying a huge amount of taxes, while the rest of the 85%, they're actually not being taxed. So how does our focus only on cigarette smokers, who make up 4% of the population, how is it going to help the remaining? We have a 28% of population on tobacco, 4% is smoking cigarettes. Remaining, you're just ignoring it. I think
excellent. No, thank you. And David, I'll bring you in here to bring a global perspective to the question that I'm going to ask you. What are the results you have seen from decisions to empower consumers as compared to decisions to ban products?
Sure. I mean, we see this on a tremendous range of issues that, if we're going to be successful on the whole idea that where we find risk, we try to reduce it, the most effective thing to do is to understand people's lived experience. Why are they behaving the way that they are? And then try to meet them where they are. Like, what can you do for them, rather than telling them what they need to do for you? And then empowering them to act on that. So when we look globally at what's happened on issues like tobacco, there's this recognition among scientists, but not among the public, that the harm is virtually all from the mode of delivery, particularly the inhalation of smoke. It's the inhalation of smoke that kills, not the nicotine people are looking for. So what can you do in empowering people with that sort of information? Because that's similar to what we did with things like, automobiles or industrial machinery or foodstuffs, to say, is there a less hazardous way you can do what you're doing? And we have seen great success in countries like Sweden with the use of an alternative to cigarettes called snus, an oral product that has very low levels of toxins. And that's given Sweden the lowest rates of cigarette smoking in the European Union. Norway, by adopting that product, reduced cigarette smoking by half in just 10 years. Japan now, just in the last 7 years, has reduced cigarette sales by almost half because of using a heated tobacco product in place of cigarettes. So we've seen lots of, and this is being replicated around the world as people get access to new products. And essentially what we're seeing is innovation. People are looking at a market globally of over 1 billion cigarette smokers. They're spending $800 billion a year buying a product most of them don't want. And we now have the technology that would allow us to replace those deadly cigarettes with something far, far less hazardous. So innovation's coming. Consumers are going to gravitate toward it. You can't stop innovation. Any country that tries to stop it just means they're handing this market to companies in other countries who will then develop it and export it globally. So we're seeing this happen. Consumers are paying attention and are in the lead on this, and we're seeing results. So I think there's huge potential, and it's a matter of how do we free that up to get the market to work for us.
Excellent. Very, very well put. Sorry, is there a question?
May I make a suggestion? If you can make it interactive, this will become more interesting.
Right.
More useful also.
Right, sir. So just context setting.
I would like to share my experience.
Can we have a mic provided?
I will share my experience of abandoning cigarette, weed, consumption of tobacco. My father was a chain smoker. Then we found a method that whenever you feel the urge of taking cigarette, to take one candy. At this work, he abandoned taking cigarettes, BDs, altogether. By practicing this thing for few months only, that he used to take candy whenever he had an urge to take BD.
You have not heard our next speaker yet, sir. I would urge you to just. No, what I'm saying is we have not heard Dr. Nimesh Desai, one of the most prolific speakers on this topic. Dr. Desai, so the next question automatically and naturally has flown to you. With your long-term experience in psychiatry and substance use, would you elaborate why harm reduction approach should be considered and why is it really worth an active consideration?
Thanks, Supratim. 40 years in psychiatry and trying to prevent and treat alcohol, drug abuse, and tobacco. One lesson that I have learned, I think, alongside the science learning, is not to hit your head against the wall. You keep hitting your head against the wall and you keep getting frustrated every time. Let me switch gears. There have been two epidemics in the last 50 years. One protracted HIV pandemic and the last one we are all aware of. Now let's elaborate. What have these two epidemics or pandemics taught us as human race or people trying to help human existence? One, behavior change is possible. But behavior change is possible if you balance the tendency to control and regulate behavior with the need for freedom and liberty. You go to either extreme, you're bound to fail. We learned that in the HIV epidemic, if I switch there. You see, initially, most countries, including this country, had a lot of problems with the needle and syringe exchange programs. You realize that if you cannot have heroin addicts abstinent, make sure you at least reduce or stop the HIV transmission through needle exchange programs. There is a number of examples from the field of what I refer to as biobehavioral disorders. Now, the thing to understand about biobehavioral disorders is that it's not only about application of medical science through technology, but also the whole issue of human behavior. And that is where pragmatism must rule over idealism. The tendency to say, I'm going to root out all causes of health trouble doesn't work. Like David said, we do know from history that better than banning is to regulate a product. The moment you ban, all that you are doing essentially is pushing it to the
underground
market.
Excellent. So I think the next question naturally to Upendra and now certain legal side of the entire discussion. Do you agree, Upendra, that safer alternatives are often plagued by insufficient and ineffective policies, and how can good legislations help in making safer alternatives available to consumers?
Sure. Thanks, Supratim. See, safer alternatives always arise from newer and upcoming technologies, healthcare innovations. Now, these are a mixed bag. They come with their challenges as well as, certain benefits. They are untreaded path. They upset the status quo. At the same time, they have huge potential, which can be very positive, can be very negative, but they're essential for the growth of any economy. Simply just writing them off doesn't work. But there's a very tricky situation from the regulator perspective, from the legal perspective. What does the regulator do? There are two alternatives. One, the regulator can, examine these technologies, have a full analysis, do the scientific data backup, understanding where it's coming from, what is the positive, negative, see global experiences, and invite the stakeholders, take everybody's inputs on that, and then come with a, thought-through legislation. Alternatively, have a knee-jerk reaction, issue some diktats completely prohibiting the thing. That will never work. As Dr. Desai mentioned, just prohibition will not work. So there are alternatives available. It's that, and many countries in the world have, used them, as David, clarified. You have various of these European countries and all over the world. When you have alternatives available, which are not available in India, they should be made available. And of course, like you asked, how legislations in countries have helped. You looked at Canada, look at the UK. You see, they have a very well-defined system. They have very defined healthcare systems, and at the same time, their economic aspects of the diseases out of cigarette smoking was so colossal that it was one of the reasons that they said, okay, let's look at alternatives, and the alternatives are working. So that way it has to be looked at. It's not just that you do it once, you have to keep evaluating what is the global impact, and then have a study of the people who switch to alternatives, and then see how it can work.
Thank you. Dr. Madan Gopal, coming back to you, okay, and this is a segue from this previous answer, I would say, how can consumer rights and policies as a general practice become more rooted in scientific studies and, broadly speaking, become more evidence-based?
We have been talking about evidence because we have been comparing the West and the Southeast Asia. The consumption pattern, as Kiran has mentioned, is 200 million. They consume and eat tobacco in other form, not smoking. They chew tobacco. If you talk about the alternatives for tobacco, there are different forms, right from Naswa to Gudaku and other things are available. They are quite rooted to that. We have to do study about the economic aspects of this. If you talk about the people, we have been taking pride in saying that our demographic dividend is there. You look at the young population, the people who are from the labor class, what BMI they are having, how many hours of work they can put in, and they are consuming around 200 rupees tobacco every day in the form of pouches. It kills their hunger, because if we have interacted with many people, it kills their hunger, so that they don't feel hungry and they can work more. That kind of addiction they are having. But with that kind of BMI, with other things affecting, if you look at the spurge in the number of infertility clinics, previously we used to have infertility clinics only in the tier 1 cities. Now it is going to the tier 3 cities. So you have to think on that aspect. Economic aspect is very, very big. It's not, you have to see that how we balance the producers as well as the consumers and the economic cost on the nation. You have to think from that perspective. For the tobacco consumption is very, very tricky and very, very difficult issue to handle. We have to find out how to prevent, because poison is poison. It was introduced 400 years back by the Portuguese. It was never part of the Indian culture. It was introduced from outside. Research should be based on the consumption of chewing tobacco, not on smoking tobacco, because smoking has reduced a lot. People have gone into alternate mechanism. We have to see that how we do that. My father was a smoker. He just one day decided that I will quit. I have not seen him smoking since my childhood. I have not seen him smoking. My mother used to say that Charminar ka packet itna bada aata tha, they used to consume it. I have not seen him smoking. He quit it like that, but that means if the harm reduction strategy which the government is having, it's not that if you look at the essential medicine list, we are having a nicotine replacement package. That is mentioned there. It's not that the intent is not there, but the intent is to reduce the harm to that extent that the expenditure on the public exchequer is reduced, because the economic cost of the tobacco-induced disease or nicotine-induced disease are very, very high.
Right. Dr. Melkote, I saw you picked up the microphone, please.
So I'll just go back to what sir was saying. So we have an obligation to look at harm reduction because we are also signatory to the WHO FCTC. Article 1 actually says that tobacco control includes harm reduction. So we have an obligation right there. Next, actually going back to what sir was saying, see, if you actually look at it, and if you are the reason why all those people continue to use tobacco is the nicotine, yes. But by itself, nicotine is not a poison, neither does it cause cancer. Otherwise, would you be having gums and pouches and patches in the market? That is unthinkable. The other thing is, talking again about, talking to a few more things, the latest census showed that the population of UP was about 23.9 crores. So the entire number of tobacco users is more than the most populous state in our country. We don't have any voice, we don't have any representation. So you have your group in the Ministry of Health which actually formulates tobacco policy. But there is no representation of a tobacco user on that group. And first thing should be nothing about me without me.
Yeah.
I think we should try and strive for looking at the views of those who actually use tobacco, look at why they actually continue to do it. And this goes, it's not like the government has not been doing things. They have been doing great things. But we also need to offer more options. If you're looking at the cessation-only approach, it has an average success rate of 0.5% a year. Why can't we give more options? There are so many newer alternatives which have worked in other countries. And of course, like Sir was saying, earlier these countries have banned it and now they have reconsidered. So you need to have agile legislation which actually adapts to the changing scenario, to the changing evidence. So if there is evidence that something works or that it can work, why not try it? Actually, leaving it as it is, then we are just going to risk a 0.5% success rate in perpetuity.
I completely agree with you. I think in every sphere of lawmaking that we are observing right now, the factor of agility, I think, needs to come in. Whether it is healthcare, whether it is technology, anything else. Otherwise, I think we will be sort of redundant very soon. David, my next question is to you. Okay, how rapidly can markets be changed and well-being improved through progressive legislations? What's your thought on that?
Well, if we look at the history of how markets have transformed with other reduced risk products, I think when the technology already exists, if we look at things like moving from unsanitary to sanitary food manufacturing, that changed markets virtually overnight. Going from impure water to clean water, you can change a market very quickly. Sometimes, like in pharmaceuticals, it takes years of research once you decide you want something safer before it can be on the market. But in this case, we already have the products. And when we look at countries and how rapidly we've seen declines in cigarette smoking, where we can reduce cigarette smoking by half in just a few years, and we need to keep in mind in all of those countries, there was usually just one alternative offered to consumers. The consumers didn't get very good information about relative risks. Taxation and regulations were not aligned in a risk proportionate way. So it's sort of like saying somebody ran a race and they did better than anybody else, but they had their shoes tied together. What would happen if a country said, we're going to make a range of alternative products available for those who would otherwise use toxic tobacco products? We are going to use a tax system to encourage people to move to the lower risk products. We're going to have differential regulation of the marketing and availability to give a disadvantage to the hazardous products. We are going to do a lot to inform consumers about the difference in risk. And I think that we could see just a seismic change in a market in a very short period of time. Could we get rid of half of cigarettes within 2 or 3 years? We probably could. Could we get rid of 80% of cigarettes and other toxic tobacco products in 3 or 4 years? I think we can. And it's a matter of which countries are going to do that and seize that initiative and create the new industries that will replace the toxic sort of products we have now.
Right. Thank you. Next one is to you, Dr. Melkote. And this is because you've been following this space for so long, so intensely. The reasons cited for banning electronic nicotine delivery system ENDS in 2019 included certain concerns like, potential health risks that, people would then go on to become cigarette smokers, otherwise who were not smokers, etc. Now, do you think, has there been any study or research regarding all these valid concerns which were raised?
They were very valid concerns. So there was a scare about, there was a very localized outbreak in the United States, which is now called as EVALI. So what happened was, it was later found out to be because of black market black market products which do not even contain nicotine. So that was actually because of that, and the main culprit there was identified as vitamin E acetate. That is number one. The other one is regarding the other latest evidence. Now, unfortunately, we do not have any sort of India-specific research, but we do have all those facts and figures from other countries where they have embraced it. So this new products, there's a very recent review from the Cochrane Society. This is in November 2022. So they examined 78 different studies. So it's a meta-analysis, study of studies, 78 different studies, and over 40 of those were RCTs, which is like the gold standard for research. Total of 22,000 cases. So in that they found high certainty evidence that newer non-combustible alternatives to smoking, they actually double the quit rate. So that, and there was also a statement by about 15 past presidents of the SRNT. They also said that we cannot ignore these any longer, especially when they have such a great potential to be a game changer. And looking at the whole sort of, the main issue that we had was these can be very attractive to children, or they can actually be a gateway to smoking for teenagers. In those countries where it has been liberalized, if you look at the UK, for example, the latest study does show an increase in usage by teens, but those who were never smokers, those who have never used tobacco earlier, for them it was largely experimental and it was less than 2%. So it's actually displacing tobacco. It's actually displacing cigarettes. Those who had never smoked cigarettes hardly were sort of going on to that. So that gateway theory also does not hold water, because if you look at the on-the-ground experience, those who had previously smoked cigarettes would be more likely to go on to that. Dual use was cited. So dual use means where one smokes normal cigarettes as well as the newer products. But that was found to be a transitional phase where one would be moving on completely to the newer products and leaving cigarettes behind. And I think that is what we are seeing right now in all those societies which are citing an increase in teen use. If you look at the teen use among never smokers, it's still low. It's still experimental. So I think that's where we are.
Thank you so much. We are running out of time, but Dr. Desai, the next question to you for a quick snapshot of this particular question. What have been the facilitators and barriers to the implementation of harm reduction approach in tobacco control, and what lessons have we learned till now, and how can we proceed from here as a country?
I guess one word answer to that would be atavism. Atavism is the inability of individuals or human race to learn from the past. I think we are learning. One must say that, as we said earlier, hitting your head against the wall doesn't help. Extreme approaches do not help. If there is one thing that, like Dr. Gopal said, if there is one thing that the current government policy and programs are doing, they are being pragmatic, they are being rational. And so we need to really look at the rationale for, as Kiran said, one, harm reduction is an obligation under FCTC. Science will tell us that HR is the approach rather than one extreme abstinence-oriented approach. One must clarify one more time that all NRT is essentially HR. So we are doing HR already. It's just that it occurs to me, I know many of us have been. I went there, you saw this cup of tea there. You go to that tea counter, besides the masala chai in the cooler, there are at least 15 kinds of tea bags. Offer choices. Offer choices to both the end consumer, the tobacco user, as well as I have been saying, the clinical service provider. If I as a clinician want to have options for what I offer to Kiran, one must have those choices. And so really, I think the idea is of being progressive, being 21st century, which we are. And as a global leader, we need to be really more pragmatic about, I keep repeating that, we have to look at biobehavioral health problems very differently. These are not pure medical problems, these are not pure social issues. These are biobehavioral issues which need pragmatism, which need the liberal approach.
Thank you so much, Dr. Desai. Time is up, but I'll ask one question to you, Upendra. What needs to be done to promote innovation and participation of large corporations in the sphere of harm reduction and smoking cessation?
See, in 2014, the government came up with a very nice thing, which is a pre-legislative consultancy process, and they advise all the ministries that you come up with a draft legislation, take everybody's inputs on board, the medical practitioners, the manufacturers, and the consumers, and as I said earlier, the global experiences. Come up with a legislation, regulate the thing. And if you don't regulate it, the way you mentioned about a ban a few years back, the products will still be available in the market. They'll go unregulated. The quality, the quantity of nicotine being used will not be monitored. Even the availability is so much easier that it's causing more harm than being able to regulate it, or cause any positive impact that way.
Thank you so much. I know time's up and it's full red in front of us. So I think we had a fabulous discussion with the most esteemed panels. Like I was mentioning that I'm sure we would overshoot time, but thanks a lot, gentlemen. It was really a pleasure speaking with you all.